Good evening and warm welcome everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for our second panel discussion on head and neck cancer awareness, things we should know. Voice of Healthcare, along with our powered by partner Merck, has taken an initiative to bring together the experts and speakers to recognize Head and Neck Cancer Awareness Month. So, without further ado, let's get started with the introduction of our esteemed panelists. I welcome Dr. Neelakshi Mahanta, Professor and Head of Department, Medical Oncology, State Cancer Institute. Welcome, Dr. Neelakshi.
Thank you. Good evening. And good evening to all the
Dr.
audience and
Kumar,
my co panelists.
thank you, ma'am, for being here. Dr. Kumar Prabhash, Associate Professor, Medical Oncology, Tata Memorial Hospital, Mumbai. Welcome, Dr. Kumar.
Thank you. Thank you. And good evening, everyone.
Dr. Jatin Sarin, Director, Medical Oncology, IV Hospitals. Welcome, Dr. Sarin.
Good evening, everyone. Regards to my co-panelists.
So, starting with the discussion, I would like to ask Dr. Prabhas, sir, what is head and neck cancer and how common are they? So, what is the burden of head and neck cancer in India?
Chronic cancer is a cancer uh, which can happen in the mouth, in the airway, till we call it hypopharynx, and below that, this whole passage gets divided into two parts. One goes for food, another one goes for air. Before that, and beyond the lip, in between area, if you have cancer, then it is comes into the area of head and neck cancer, and that includes many subgroups. I mentioned some, but for clarity, it includes oral cavity cancer, oropharynx area, that is behind the mouth, then nasopharynx area, that is above the oropharynx and above oral cavity. Then below oral cavity, there is an area called larynx, and then around the area of larynx, larynx is the voice box. Around the area you have a space called hypopharynx, and these are all areas which comes under the classical head and neck cancer. I'm sure the audience might also hear the areas like what happens to area beyond in nearby in oral cavity, like maxilla, that's air space we have. Then brain, that many times we club it together or we keep it bit separately. And also many times you do have cancers in the gland area in head and neck. So like and the names we call it like salivary gland, because of which we get saliva, and also thyroid. But usually they are usually kept separately. But many times if you get to hear these, you we understand they are happens in the same area. But having said that, usually they are not clubbed together. Coming to what is the burden? The burden of head and neck cancer is the commonest cancer in India, and that's primarily because of tobacco use. And almost 20% of the cancer in India is head and neck cancer. So if we have around some, the projected number in today's time is that we have around 13 to 14 lakh new cancer patients in India every year today. So we put 20%, and then you get a hang of it that almost 2.5 lakh new cancer patients of head and neck happens in India every year. In fact, because of this oral cavity cancer primarily, and driven by oral cavity cancer, India is also considered the capital of oral cavity cancer, because the number of oral cavity cancer India has, that is maximum in the world. And again, that's because of tobacco habit. So this may give you a approximate hang of it, the numbers of head and neck cancer in Indian context.
Thank you so much, Dr. Prabhas. As a dentist myself, I know that oral cavity cancer is one of the major cancer in which India has a lot to a major role. A major part of oral and head and neck cancer comes from India, and it is you have rightly mentioned due to the use of tobacco. And also you have elaborated the type of parts that are included in head and neck cancer. So building upon that, Dr. Neelakshi, I would like to ask you that what are the main types of head and neck cancers that are there? Ma'am, you are on mute.
Thank you so much. And Dr. Prabhas has already highlighted about how we broadly classify head and neck cancers. And as we all know that this head and neck region, when we talk about our identities as human beings, the face, the head and neck is the first, presentation of every human being, and that becomes a very important area of a body of our body when you compare it with any other part of the body. So when you have something like a cancer in this region, it has a huge impact on the person, on the person's basic identity, and all the the gruesome features that come along with the burden of cancer. And not only that, not the disease itself, but also the effects of the treatment, which can be very mutilating and can have serious impacts on the the contour of the face, on how the person would look like, on how the person's basic quality of life is going to be during the course of the disease and the course of the treatment. So this is a very, very primarily probably one of the most important regions. And as Dr. Prabhas has already highlighted, when we classify the head and neck cancers, we primarily talk about the oral cavity. And when we say about the oral cavity, it includes we start from the lips and then from into the gums and the anterior two-third of the tongue, the inner linings of the cheek, and the portion just behind the molar, that's the retromolar trigon. So these are the primarily, and the hard palate, which comes under the oral cavity. And behind that lies the pharynx, which is divided into the nasopharynx, that is the part behind the nose. And then comes the oropharynx, that's the part behind the oral cavity. And then comes to the hypopharynx, that's below the hyoid bone. And below that is the most important part, that just now, like the way I am talking, it's all because my voice box is intact, and I can talk, I can sing, I can basically it is all because of my larynx, which is functional. So when the cancer affects this tiny little space, that is the voice box, which is a very, very common cancer, especially in elderly, in the aging population who have been chronic smokers for a long period of time. The laryngeal cancer is a very, very serious kind of a cancer, where people with different kinds of professions, like professors, lecturers, teachers, people who need to speak, they start having affections of their voice, or the voice becomes hoarse and they are unable to speak. And not only that, even the treatment could possibly affect, if it's in an advanced stage and the patient requires something like a laryngectomy, it could probably lead to a loss of voice, and the person can have a huge it can have a huge impact on his quality of life. So these are basically the parts of the pharyngeal cancers. And apart from that, of course, you have the as sir has already said, about the salivary glands, about the thyroid, the parotid glands, and also the sinuses, which are the empty spaces just behind our cheek. So, cancer can occur in any part. And this is a very complex and a very sophisticated region, which, from outside may look, where it looks nice and simple and smiling. And, imagine the million people having different facial features. But behind the scene, just when you go behind the scene, the skull and all the complex areas behind are an extremely, extremely sophisticated part. And any cancer in this region, the treatment can affect all the neighboring structures, because they are all very condensed in a very small and complex area. So keeping this area preserved and free from cancer is extremely, extremely important for humanity at large.
Thank you so much, Dr. Neelakshi. I think you have highlighted majorly 2 points, that it's the aesthetic region of the body, our face, and if it affects that. And apart from the aesthetics, it disturbs the patients mentally and psychology as well, because of the regions that are involved. If the
Absolutely.
cancer spreads to the areas, and talking about the symptoms of head and neck cancer, Dr. Sarin, sir, what are the signs and symptoms of head and neck cancer, and what are the important risk factors associated with head and neck cancers, apart from the tobacco use that Dr. Kumar has already highlighted?
Yeah. uh, Actually, my esteemed panelist has very elaborately said that head and neck is a very broad category. There are so many subsites. So the symptoms of head and neck cancer depend on at which subsite you are getting a cancer. Suppose you're getting a cancer at a oral cavity, the commonest symptoms, you being a dentist, must also be seeing the any ulceration in the mouth or some kind of a growth.
Or
uh,
white patches or red patches
White
in mouth?
is so that is a kind of a precancerous lesion rather. Any kind of red patch with ulceration, this is the commonest symptom for which a person approaches you basically. And also you guys tend to have a suspicion that this he or she might be harboring head and neck cancer. The second most common symptom of any subside, this was about oral cavity. The second most common symptom of any subside, be it larynx, be it hypopharynx, is the presence or absence of neck nodes, the nodes in the neck. Sometimes you get these nodes or swellings which gradually increase in size. Initially, they are mobile and then they become fixed. So, and there are cases in which you hardly have any primary located inside and you get a node only. So, that is also a common condition. I mean, it's not so uncommon. I mean, there are 7% of cases we get where you get only nodes. Then, for larynx, everybody knows the most important symptom is hoarseness of voice, difficulty in swallowing, pain while swallowing, or any kind of the speech also. Sometimes when there is a cancer in the tongue and it gets fixed or something, then or there is a cancer at the posterior region of the tongue, you have a speech which is commonly called a hot potato speech. So you tend to have a very strange, kind of phonation and words, what the person speaks, because there is a presence of a lump or some kind of a fixation of tongue is there, and a person is not able to speak clearly. Hoarseness, as I said, is very important symptom, and difficulty in swallowing food. So these are the common symptoms, and the other very subtle symptom which you get in head and neck cancer is pain in the ear. Suppose you have some kind of a cancer inside pharynx or larynx or somewhere in the posterior part of oral cavity. You get tend to get a referred pain in the on the same side of ear, and that is called otalgia. So ear ache, person presents with ear ache. Some people also get a recurrent ear infections also, especially in cancers of nasopharynx, the pharynx behind the nasal cavity. So you tend to get recurrent serous otitis media. That it is a kind of a inner middle ear infection. So these are some subtle signs, and any ENT guy should be really careful while examining these patients for simple ear infections also, that there might be some harm. You being a dentist must have seen a lot of ulceration on the gum and loosening of teeth in GB sulcus tumors or gum tumor. Sometimes there is a very expansile lesion in a very rare kind of head and neck cancer called amyloblastoma. So the
Increase
commonest
in the growth of bones. Yes.
bone, yeah.
Yes.
So it's and sometimes the bones of the head and neck are affected because of some systemic cancers also. Then
Metastasis.
in tonsils, sometimes enlarged tonsils can not only be simply a head and neck cancer, it can be a part of a lymphoma. So all kinds of symptoms are there. And as my co-panelists have very clearly elaborated, and you also know that tobacco is a numero uno reason for having this kind of malignancy, whether smoked or smokeless tobacco. And in India, the smokeless tobacco, which is being consumed at still in a pretty large amount in certain regions of our country, especially Western UP, Gujarat, Maharashtra. So all these places, they are, populations which actually are used to study such kinds of cancer, because it's very, very common at those places. The other important reasons in places like the place where I stay, that is Punjab, where smoking is not that much prevalent, is the bad dental hygiene and bad teeth, and alcohol also adds to the insult. So that is the second important reason. The third important reason, which is also prevalent in Western countries, that is infection with human papilloma virus. So, some certain strains of human papilloma virus have been implicated in the causation of head and neck cancer. So, these are the common causes of or common risk factors for head and neck cancer. Thank you.
Yes, thank you so much, Dr. Sareen, for elaborating the signs and symptom parts. So, and the risk factors apart from the tobaccos, whether it's smokeless or whether it's smoking the tobacco. So, we have discussed about the burden of head and neck cancer, the types of head and neck cancers are there, and the signs and symptoms. So, moving on to the diagnostics part of head and neck cancers, Dr. Nilakshi, I would like to ask you, ma'am, how are head and neck cancer diagnosed, and what are the different stages of head and neck cancer, and can a head and neck cancer spread to other parts of the body as well?
Yeah. So, yeah, certainly head and neck cancers, coming to the last part of your question, it can spread to any part of the body, especially when it is in an advanced stage. And the saddest part is that in our country, and especially in our part of the region that is from the northeast part of India, we also have the dubious distinction of carrying the highest burden of head and neck cancers when it comes to the demographic profile of cancers in India. And this is again because of many of the high risk behaviors which Dr. Sarin has already highlighted. And in this part of the region, we have a lot of oral cancers, primarily because of excessive ingestion of different kinds of smoking as well as smokeless tobaccos. And one of the major culprits is the betel quid, the betel nut, which is taken either with the erica nut or with lime, and usually that is kept inside the mouth for a very long period of time. Apart from that, another major huge chunk of population that we are seeing are the adolescent and the young adults who are indulging in very, very high risk behaviors of using various kinds of smoking as well as smokeless tobaccos. And I think that a very important target group that the country actually needs to focus on is the preteen and the adolescent age group, where out of curiosity, out of peer pressure, out of a feeling of, being a little adventurous or trying out something new, which is normal human behavior, of course, but if it is not, kind of under any guidance, then it could be very dangerous, and it is already setting a very, very dangerous trend in our country. So we are seeing a large number of this group, and once they fall in that trap, it's almost a point of no return. Like, they go spiraling down, and then after that it's impossible for them to leave, because they are already caught in the web of addiction. So when you asked me that how do we diagnose these head and neck cancers, I would say that the first diagnosis would start with, before even diagnosis, one needs to have awareness. So if your mind, does not know, the eyes cannot see. So obviously, you need to know what you want to look for or what you want to see. And when I'm saying what you want to see, I'm not talking about what the doctor is wanting to see. It is about the individual. What does he want to look for in his head and neck region to identify whether something has cropped up, and especially for those who are already indulging in high risk behavior. So this becomes a very, very important message, which should be, almost hammered, I think, on a very, very war footing, I would say, to address that category of youth who are indulging in this kind of high risk behavior. We have tried various kind of campaigns, like, putting very gruesome photographs on the cigarette packings and the tobacco packets, but I really don't know how much of all this is working, because the youth think that they can, kind of get away with anything and everything. They only have to come to a cancer hospital to see people of their age group who are coming with stage 4 head and neck cancers. So only probably if they see somebody of their own, or when they themselves might land up in the hospital, would they realize how late it has been. So awareness is the key. And how does this awareness come in? It comes in with education. And how does this education come in? It comes with information. And where does this information come in? It can come in from various sources, but first of all, it has to start within the family. Now, it is no point of a mother or a father telling a child that don't do this and don't do that, when they themselves could be indulging in that kind of a behavior. So if you have somebody who's smoking in the house, a father who is regularly smoking in the house, if he tells his son that don't smoke, why would that son listen? Or if betel nut chewing is a practice within the household, and everybody is having that, and the daughter also, starts taking up that habit, it would she would feel that, she's just doing the right thing. So no amount of, there'd be nothing that is stopping her, because she sees everybody around her doing it. So awareness will come with right information and right education. So I think this is where the public health comes in, and they need to campaign on a war footing to tell what are the things and what are the carcinogens which are leading to this. Now, once they know, they have that awareness, and if they are practicing high risk behavior, even if they are not practicing high risk behavior, they would know that the first thing would come with inspecting their own oral cavity and maintaining a good oral hygiene. So, maintenance of a good oral hygiene, maintaining healthy lifestyle practices, avoiding all kinds of addicting substances which are known factors and having known carcinogens for cancer, they have to be totally shunned, banned, avoided, and the message has to spread. The message has to spread in their own schools, in their own classrooms, in their own communities, amongst their own friend circles, through campaigns and through various kinds of, educational means. So when they have to inspect their oral cavity, what are they going to look for? So they should know, there could be signs of redness, there could be a ulcer which does not heal, there could be bleeding, there could be some sore, or any swelling or an unusual kind of a growth. So these are some of the things which they should be looking for when they inspect themselves. Apart from this, that is their own self-examination. But beyond this, there could be other screening programs by which the the detection of head and neck cancers can be higher. So this could be population-based screenings, which can where you can go to various communities and do a screening, because head and neck cancers can be detected very easily just on visual inspection. So a good visual inspection of the oral cavity can capture a lot of head and neck cancers which might have gone undetected, or which the patient might have kind of ignored. The other could be an opportunistic screening for those people who come to hospitals for other reasons, but they have high risk behaviors, and therefore they can be routed to the tobacco the screening program, the head and neck screening programs, where they could have an inspection of their oral cavity to find out whether they could be having any suspicious lesion in their mouth or oral cavity, from which a biopsy or a cytology should be taken. So once after inspecting the part, if there is any suspicious lesion, then definitely cytology, or an aspiration or a slide examination, or a biopsy. If it's a larger lesion, a biopsy might be required to identify what is the type of cancer. Now, that is coming to the diagnosis of the cancer. Usually in the head and neck region, we get squamous cell carcinomas, which is the commonest type. But as Dr. Sarin has also said, that yes, we do see lymphomas, we do see various other, very peculiar kind of, even sarcomatous lesions, and, um, adenoid mucoid various other kinds of sarcomatous and even neuroendocrine tumors we have seen. Very strange presentations in this region also can occur, but lymphoma is a pretty common presentation that we have seen. Those are of course the rare varieties. And therefore, after the cytology or the biopsy, the next would be staging it. So for the staging, imagings would be required. We would probably require a CT scan of the neck, and if it is locally advanced, there are neck nodes, then we could think of, probably we might have to go for PET CT scan also if it is available, or even CT would do to tell us whether it has gone to the lung. The commonest sites that we can see where it could spread would be, apart from the regional lymph nodes, it could go to the lungs, it could go to the liver, it could go to the adrenals, it could go to the brain, it could go to the bones. So we have a standard classification, as we all are aware, that is the TNM classification. And this classification is based on the tumor size, the nodal burden, and the metastatic size. And depending on this is the staging, and based on the staging is the treatment plan. So the treatment plan would be decided based on the stage of the cancer, whether it could be a combination or a sequencing of surgery versus radiation versus chemotherapy or any other targeted therapy. So yes, head and neck cancers can be from any stage, from stage 1 to stage 4, but the whole aim should be focused on trying to capture the disease at the earliest of the stages, so that a simple excision or surgical removal would be enough to treat the patient. But when it becomes locally advanced, there are the other modalities will have to be, they will step in, and the treatment gets more and more lengthy as well as complicated. So yeah, that's the scenario of head and neck cancers and how they can go to different parts of the body.
Thank you so much, Dr. Neelakshi. I think you have very elaborately explained the diagnostic and the staging part of it. And apart from that, the main point that you have highlighted, that is the awareness and education regarding head and neck cancers in India, and the need to be diagnosed should come from within the individual. So that is a very important point that you made, that they should also see the kind of symptoms that they are having sometimes. So it happens that patient is having some ulceration or anything in the oral cavity, but they don't come to the doctor. So you said that youngsters are there that are off stage 4 cancers that are present. So I think it should come from within the person, that I have some kind of symptoms and I should get to the doctor to get it treated. So thank you very much for elaborating that part as well. And you have talked about the staging and the treatment part of it. So moving on to that, I would like to ask Dr. Sareen sir, how is head and neck cancer? Dr. Nilakshi has told about the surgical chemotherapy and radiation part of it. So, what are the goals of these treatment, and is surgery required for all the patients?
Yeah, it was very extensively elaborated by my co-panelist. First let's go to the staging. Head and neck cancer is one such cancer that if the cancer stays up till neck also, then also it can become stage 4. This is the irony of it. I mean, it doesn't require to spread to other places to be a stage 4 disease. If it is having a large fixed nodes or any uh, thing of that sort, it becomes stage 4. So unfortunately, maybe let it be any subsite, the people in our country usually presents in stage 4 unless and until they are aware themselves, and they approach the doctor. It's not that early cancers are not getting detected. So about the treatment part, the goal of treatment is to eradicate the cancer from the primary site and neck node. So that is the goal of treatment of head and neck cancer. Simultaneously, one has to maintain post treatment quality of life and functional quality of life of the patient. So, that is the second most important goal of the treatment of head and neck cancer. The third most important goal of the cancer is to prevent the relapse of cancer and be aware uh, that uh, what are the factors that may lead to relapse. And fourth is if the relapse can also be adequately managed. So, so these are the four important things that we look into while we manage head and neck cancer. Early stage cancers, especially of oral cavity, are treated with surgery. Oral cavity is mostly an accessible place, and you do surgeries for oral cavity. All kinds of surgery is done, and the important component of surgery is that the reconstruction part. So very good reconstruction techniques are available, that the people are able to even reconstruct, the surgeons are able to reconstruct the exact jaw lining also if they have to remove, which they have to in many cases. So the surgery has progressed by leaps and bounds, so has the other treatment modality. And oral cavity is one site where, be it a cancer of tongue, be it cancer of lip, be it cancer of cheek, be it cancer of GB sulcus, surgery in early stage is a curative thing, and a few cases go on to require radiation. If we go down, if we go to the posterior part of the tongue, if we go to the tonsils, if we go to the to larynx, or maybe hypopharynx, here surgery is actually quite difficult and very mutilating, because the it's just not about eradicating the disease, it is about maintaining or preserving the functional integrity of that part. It is very easy to reconstruct the things, not easy, I mean, it is tough for oral cavity cancers also, but for base of tongue, for larynx, for hypopharynx, it is really tough. And the important goal then comes of chemotherapy and radiotherapy. Radiotherapy is the backbone, and chemotherapy adds on to the results what we obtain from radiotherapy alone. So, so in that context, there have been a lot of developments which my co-panelist will further allude to. That how chemotherapy along with radiation has led to very good results in such difficult to treat cancers. Even if you progress to stage 3 or stage 4, there are definite percentages of patients who are getting cured. They don't relapse. So that is the importance of chemotherapy and radiotherapy. uh, Actually, the cancer patient should be guided properly. I have seen the head and neck cancer patients getting misguided. The people who require surgery, just because to avoid surgery they tend to take radiation or chemotherapy. That is a wrong thing. Absolutely. If or if someone requires radiation, they tend to do away with. I mean, they tend to shy away from the radiation. See, for head and neck cancer, for any particular subsite, there are no shortcuts. There are certain principles which you have to follow, and if you somehow tend to sway from these principles, that should be in a proper clinical trial setting. Otherwise, it should not be there. And one should stick to the standard of care. We cannot even say about the dosages of radiation and chemotherapy. So it is that important, because otherwise we won't obtain that outcome, including the functional outcome. There could be very, very severe long term treatment effects if we don't stick to the standard of care. So that is very important. I really want to stress that. And rehabilitation post treatment, sometimes, for relapse disease, or for some tumors of larynx, you have to go for surgery, so a voice box is removed. So there are certain devices available which are implanted, and you can a person can still have some kind of a artificial voice. But usually the first line, treatment is always, in such cases where you can do away without a mutilating surgery, is chemoradiation. So these are about the treatment aspect of the things. And when they become really advanced, as Dr. Nilakshi said, that this they can spread to any part. The commonest site they spread to is lungs, and that is where the role of chemotherapy and newer targeted therapies or immunotherapies come into picture. And such patients are also now going on and living a reasonable amount of time with good quality of life with the current treatments available. Thank you.
Thank you so much, Dr. Sareen, for extensively elaborating the types of treatment that are required based on the targeted area of cancer, and the goals of the treatment for each stage of cancer, for that matter. And you have talked about chemoradiotherapy. So I would like to ask Dr. Prabhas, sir, what are the common chemotherapy, targeted therapy, and immunotherapy agents that are used in the treatment of head and neck cancers?
So chemotherapy, they are used in multiple settings. Starting with one is it is used with when radiotherapy is being given, as told by my co-panelist. And in that situation, the chemotherapy which is used, the most important remains a drug named cisplatinum. But you do have many other alternative, like having drug called 5-FU and carboplatinum, paclitaxel and carboplatinum. Then patients which are not eligible for cisplatinum, then to consider for docetaxel, or we do have cisplatinum, which is given in two ways. One is to be given every 3 weekly, or to be given every weekly. Coming to targeted therapy in the same situation, there are two of them which is regularly used, and one is called cetuximab, which is targeted therapy for target called EGFR, or nimatuzumab is another drug made by one Indian company, and again can be used with radiotherapy alone or in combination with chemotherapy. So these are the various targeted therapy and chemotherapy which can be used with radiotherapy. Now there are situations where chemotherapy is used first, then followed by surgery or radiotherapy, and what we call it that neoadjuvant chemotherapy. And in those situations, the chemotherapy used are combination, and usually the combination is docetaxel plus cisplatinum plus 5-FU. One can also consider using it two drugs, that is called docetaxel plus cisplatinum or paclitaxel plus cisplatinum in this setting. And you have another situation is when after you're giving chemotherapy, and after chemotherapy one can use with radiotherapy treatment, and that time usually one can use cisplatinum, carboplatinum, or cetuximab or nimatuzumab in that setting. Subsequently, another setting where we use these chemotherapy, targeted therapy, and immunotherapy is when the disease has come back, and in that situation disease can't be removed, and we call it palliative setting. In those settings, the treatment option is immunotherapy, drug named pembrolizumab, which can be used in combination with 5-FU plus cisplatinum or taxane plus cisplatinum in these patients. Apart from that, other option is to use cetuximab again, which is a targeted therapy with chemotherapy, and one of them either 5-FU plus cisplatinum or taxane plus cisplatinum. If the patient disease progresses on this pembrolizumab or nivolumab in this setting. Apart from these, the options for the patients are the drug treatment which we have developed here at Tata Hospital, and what we call triple metronomic chemotherapy plus low dose nivolumab. And because those previous treatment what we suggested is costly and only 5% of our patients can use it, so this option remains with the patient if they can use this treatment. If they can't use this treatment, then only triple metronomic chemotherapy is a fair option in these patients. And if not that also, then again a treatment developed by us is what we call double metronomic chemotherapy, and the drugs used is methotrexate, celecoxib, and erlotinib for triple metronomic chemotherapy. And for double metronomic chemotherapy, the drug used is methotrexate plus celecoxib in these settings. So these are the various drugs which are used in various settings in head and neck cancer at present. And all the treatment what I have suggested is the treatment for squamous cell carcinoma. There are many other sites which I mentioned. They have some other treatment available for them. If required, those can be used. But I think so today looks like we are primarily focusing on the squamous cell carcinoma of head and neck cancer. So these are the various treatment which I mentioned.
Thank you so much, Dr. Kumar, for elaborating the treatment part of it, a part of head and neck cancer, especially the squamous cell carcinoma that we have talked about, the different stages and the type of treatment that are used for different types of situations for the cancer. So we have talked about the types of head and neck cancer, symptoms, the diagnostic part of it, and the treatment part of it. Moving on to the recurrence of head and neck cancer. So, Dr. Kumar, sir, what are the chances of survival in head and neck cancer patients, and and can it reoccur? What is the recurrence rate in these type of cancer? And what care should be taken during treatment or post-treatment completion for head and neck cancer patients?
So head and neck cancer, as by now we do know that there are various types and various sites, and those if we take a ballpark figure, I'll talk about ballpark figure, then we'll go by the different sites. because different sites they do have a different prognosis with the treatment. So if you take the ballpark figure, then almost 5 years survival of these patients, if we take all of them together, that is around 40 to 50%. But that will be a ballpark figure, but that doesn't mean that's true for every stage and every site. Now, if we take nasopharyngeal cancer, then in nasopharyngeal cancer, the early stage, majority of the cancer gets treated and cured. So if we take those T1 T2 disease, then it appears that almost 95% and beyond the cancer can remain disease free if treated properly and if done a good job. In the locally advanced tumor, if again the full treatment is given, that includes chemotherapy, then chemoradiation, then maybe adjuvant chemotherapy if required, then in those settings also almost two-thirds patients then they have a chance to live long term. That is for nasopharyngeal cancer. Now coming to oropharyngeal cancer, the early stage we do expect that more than two-thirds of the patients they will live long term. But in locally advanced tumor, when the tumors are bigger, then we expect almost half the patients to survive long term. That is around 40 to 50%. Now, to oropharyngeal cancer, that depends upon if it is HPV-16 or not positive. That is one of the infection which can cause it. If it is positive, then majority of the patients they do live long term, especially if they don't have tobacco or they don't eat tobacco. If they are HPV negative, then we do expect overall almost half the patient to live long term in locally advanced and more than two-thirds to live long term in localized tumor if treated properly. In melangeal cancer, which is the voice box, in those patients with voice box, if again you have an early tumor, T1, T2, that's the terminology we use, then majority, maybe more than two-thirds or almost 90% and beyond patients can live long term with small treatment required for them. In the locally advanced, which is the bigger tumor, we do expect half the patient to survive long term. And you do have a tumor next to larynx, what we call hypopharynx. They have a bit poorer prognosis and, or I'll say, bad prognosis. And if we give the treatment, if the tumor is bigger, then in long term we expect 15 to 20% patient to live long term. And in if it is small tumor, then only 30 to 40% patient may live long term. So it appears in the different site and different stage decides that what percentage of patient will live long term with this treatment available.
You are on mute, Dr. Kumar.
Oh, no, that was idea. So different tumor
Okay.
and different sites, and with the appropriate treatment, do have a different outcome depending upon the sites and the stage. What we have for this head and neck cancers.
So, thank you so much, Dr. Kumar. So, what I will take from this is that in the early stages of head and neck cancer, the chances of survival are more. So, that is what I got from the elaborative part that you have explained according to the different stages. So before concluding this session, there are a few questions from our audience that I want to take up. Yes. So yes, there is one question regarding the hereditary. So I'll keep on the screen. So is head and neck cancer hereditary? So I'll ask this to Dr. Neelakshi. Ma'am, would you like to answer this question?
Um, per se, actually, head and neck cancers are primarily like a risk factor associated diseases, the squamous cell carcinoma group. And as we have already extensively elaborated on all the risk factors, so they are the primary reason for developing these cancers. However, nowadays we do have a lot of techniques for getting into the genetic profiling of the patients, and there could be certain kinds of mutations which make a particular subset of patients more prone. But all said and done, the focus should be on the modifiable risk factors when it comes to head and neck cancers.
Yes, thank you so much, ma'am, for answering that. There is one other question. So, for especially Dr. Jatin, sir, are there any screening protocols for head and neck cancer?
Well, actually, there's no assigned screening protocol, but any aware person or a habitual tobacco chewer or smoker can actually see their ENT guy or a dentist or the oncologist to look for any lesions. And these days, people being aware, because head and neck cancer is rampant even in places where people are not taking all these things. So with the slightest of the changes in their tongue or cheek, or maybe persistent hoarseness or anything, they come for a checkup. And if Screening actually is actually a process by which you tend to check for precancerous lesion. And precancerous lesions are very common in the people who are addicted to tobacco. And one of the lesion, as you rightly said, was white patches, that is also called leukoplakia. There are very young patients also, young kids or young adults who have submucous fibrosis. Their mouth doesn't open properly. So that's because the inner lining has become hard because of tobacco chewing. And yeah, so such people, they do require screening. There must be a good screening protocol going on in, I believe, Tata. My colleague would be the right person to answer that. But I, being in a private practice, we don't have any such protocol in our institution. But mostly in government setup, my co-panelists will tell you there might be some screening protocols available.
Yes, sir. Thank you. Thank you so much, Dr. Sareen, for answering that question. And we have one more question which is relevant to this. So I would like to ask Dr. Neelakshi, ma'am, what can be done to improve access to care for individuals with head and neck cancer?
What can be done to improve access to care for individuals with head and neck cancers? Yes, accessibility. I think the government is taking major steps to make cancer care as a whole, not just for head and neck cancers, but to make it reachable to the doorsteps of the people. As you know, like even in Assam, in the northeast region, which is beyond the chicken neck of the country, we are now coming up with a large number of cancer centers which are under the government. And there's a proposal of 19 centers coming up, but we already have about 8 centers which are already functional. So the whole idea, basic idea, is that when you have these cancer centers which have the facilities of say at least some kind of surgical treatment, access to chemotherapy, and even access to radiation. So even small towns in Assam are now having centers where radiation facilities are available. So this is a huge mammoth step taken by the government, seeing the ever increasing burden of cancer, because cancer in the country. And earlier, at least a decade or so earlier, the care of cancer or accessibility to cancer care was only available to a few selected metro cities in the country. So, coming from Assam, I can very well say that our patients had to travel very, very long distances to get their basic, the diagnosis and the treatment, which would go on for several months, and which was a huge depletion of their resources, their financial resources, and all other kind of care that a cancer patient, in the journey of the cancer patient. So these patients often would have to go and station themselves in Mumbai or in Chennai, and have various barriers of financial barriers, cultural barriers, climatic differences, food differences, language barriers. Despite all these barriers, they would have to stay for 7, 8, 9 months, and that would almost deplete all their available resources. And eventually, these patients are usually anyway diagnosed very late, and they are palliative cases. So it is actually a very sad story. So accessibility has been taken up definitely by the government, and we are having a large number of cancer centers where basic diagnostic facilities are there, basic imaging facilities are there, and the primary treatment facilities are also there. So like even in a place like Assam, we are giving not just chemotherapy, but also targeted therapy, immunotherapy. These things are available today. So I think access has come in, but what is probably more needed is awareness and education. I would like to highlight on that part mostly, because that is how we can reach a larger audience. And schools, I think a focus should be there to make disseminate all these information in the schools, especially for the youngsters who are, say, somewhere around class 7, 8. That's the time when they have a tendency to pick up a habit like this, and that is where we should nip it in the bud. So, if we want to nip this problem in the bud, we should go and target that particular segment across the country, across all sectors, across all socioeconomic classes, whether it's in the metros, whether it's in the tier two cities, or in the villages, rural, urban, across the country. I think if we target that section or that segment, I think it would cause some kind of a change in mindset of the youngsters or the youth, who are the future of this country. Once they realize that this bad habit is only going to be disastrous for them, then I think that could be a wake up call where we can see a change. So when it comes to access, it's not just access to treatment after the disease has occurred, it's also access to information to prevent the disease from occurring.
Thank you so much, Dr. Neelakshi. I think you have very wonderfully explained, uh, uh, you know, uh, the kind of population that needs to be targeted for awareness and education, the high risk people, and probably then we can talk about the access to care once we diagnose them early, once they are aware, and once they have the knowledge for. For any type of cancer for that matter. So, with this, I would like to conclude this session here. I would like to thank all the panelists for taking time for such a critical discussion today regarding head and neck cancer. So, thank you so much, Dr. Nilakshi, Dr. Sarin, and Dr. Kumar Prabhas. I think there was some network issue from his end, so he has left early. So thank you so much, Dr. Lakshi and Dr. Sareen again for joining
Thank
us
you,
for this
Dr.
session.
Ritika. Thank you, Dr. Sarin. It's a pleasure meeting you on this panel.
Thank
And
you, Dr.
Mr. Kumar Prabhash.
Same here. Yeah. Thank you very much. Nice
Thank you
meeting you.
so much. Thank you.